Over to you, Dr. Kanesh.
Yeah. Hi, good evening, everyone. So I welcome you all. But before I welcome you all, I want all of you to listen to what Dr. Talwar sir has to say before the initiation of this program. Can we have Dr. Talwar sir, please?
Dear friends, welcome to second episode of PACS International Web Symposium. And today we are going to discuss persistent air leak, particularly alveolar type. And our expert today is going to be Professor Rakesh Panchal, who is from the University of Leicester in UK. The program is going to be moderated by Professor Richa Gupta, head of the department CMC Vellore, and we are going to join today by two panelists who are quite experienced in interventional pulmonology, Dr. Jayaraj P. Nair, who is from Sion Hospital, Mumbai, and Dr. Balaraju Tadikonde, who is from the Vishakhapatnam city. So this program is going to be live with the lot of questions and discussions and panel discussion. So participate and ask as much as questions you can, and whatever your queries are must be solved today itself on this topic. I hand over the proceedings of this web symposium to your host, Dr. Kanish Kumar.
So hello, everyone. So as said by Dr. Talwar sir, he introduced all of you to our moderator, which is Dr. Richa Gupta ma'am, and our international expert is there with Dr. Rakesh Panchal, and we'll be having two of our national panelists with us, and then we'll be having a lot of questions. So idea is to relive those moments, whatever happened in PACS 24, because I wanted the reach to go beyond the people who have attended the conference, and everybody should learn from it. And the idea is to get involved in the discussion through the questions from the audience. So I want all of you to put their question in the chat box so that we can discuss it later on in the later part of the conference. And personally, I also feel that pleural diseases are sometimes very difficult. When it's easy to treat, it's very easy, but when it's get difficult, then definitely you need to have a multidisciplinary kind of discussion with the thoracic surgeon as well sometimes. And sometimes it's always easy because our international expert like Dr. Rakesh Panchal is with us, and he will share his experiences, whatever he has done over there in the Lister. And now we will be proceeding with the lecture of Dr. Rakesh Panchal. So I would request Sipla people to please play the lecture, and then later on Dr. Richa ma'am will be taking the moderation part.
So in the next 10-15 minutes, I'm going to talk to you a little bit about, so the remit of my talk is pleurodesis and persistent air leaks, but I wouldn't do the talk justice without talking about the causes of persistent air leaks and the other various treatment modalities that are available to us. So I've got no conflict of interests. For those of you interested, there's this excellent review article by David Feller-Kopman, which is freely accessible via PubMed if you wish to see, have an update on this topic area. You also saw that this book was launched earlier on, and my good friend Nagarjuna is the key or main author and editor of it, and I had the benefit of editing the plural chapters, and there is a nice section on persistent air leaks in the book. Right, so you all know what a persistent air leak is. It complicates about 30% of pneumothoraces, and we're talking about bronchopleural fistulas and alveolar pleural fistulas. We have a surgical colleague on the panel, and bronchopleural fistulas will be largely following surgical complications, and as pulmonologists, the main ones we're going to be dealing with are probably alveolar pleural fistulas. You're all aware that these are challenging. There's no robust evidence, no clear consensus. It's a significant cause of morbidity, and these patients languish on our wards. And I don't have all the answers, but I'm going to try and take you through an approach. So we know thoracic surgery is a main cause of sort of bronchoalveolar fistulas, bullous disease, cavitatory lung infection, which you'll be much more familiar with than I in this part of the world. And then it's not just bullous disease or surgical complications, but Mark Noppen's group from Belgium stated that the visceral pleura is actually porous. So in this slide at the bottom here that you can see, They gave inhaled fluorescein to patients who had previous pneumothoraces, and they found out that these patients actually had a porous visceral pleura. So perhaps the visceral pleura may be leaking air, and this is the basis for potential pleurectomy or pleural ablation when we send our pneumothorax patients to our surgical colleagues. We think of the lobes of the lungs as being discrete entities. However, that is not the case. There is intra and interlobar collateral ventilation, which may be exacerbating these air leaks. So the management. So there's conservative management. We put a chest drain in all of these patients. You may put a Seldinger chest drain in. You may put a surgical wide-bore drain in. You'll try and put a Heimlich valve on it or an ambulatory bag and ambulate the patient. We have chemical pleurodesis, blood patch, endobronchial valves, which I know are not available in India at present. And obviously, most of these patients will be referred to our surgical colleagues, but we end up managing a lot of the patients which are not suitable for surgery. There are a number of other approaches as well, which I'll allude to shortly. So when we have a persistent air leak after 5 days, the only way we know this is happening is by a persistent bubbling chest drain. However, there are digital devices around. So there's the Topaz device by Medela, which is able to measure the volume of a leak, as you can see here, and you can apply pressure or negative suction or suction or negative pressure as well, and it will tell you what the flow rate is, and if it's a large air leak, the flow will be much higher. There's also the portable suction unit available by Rocket Medical. So these are the two main portable or digital suction devices. Sofolio had a classification of air leak, which Dr. Saxena will be familiar with, where there's 4 grades, depending on whether it's during forced expiration, inspiration, or continuously bubbling chest drain. In reality, this classification doesn't really help us, because the treatment depends on the condition of the patient, the severity, and the underlying etiology. So, chest drain will suffice in the majority of patients. In a primary pneumothorax, by 7 days, if you hold your nerve, 3/4 of these, according to this study, will have resolved. And in a secondary pneumothorax, which is more common, about 2/3 should have resolved by a week. If they haven't, you can try and put a Heimlich valve on your chest drain and ambulate the patient. You could put an ambulatory bag on. And in some cases, I put an indwelling pleural catheter in these patients as well to allow them to get out of hospital and go home. A chest drain ideally should only be in the chest for about, ideally, 3 weeks. Anything longer than that, high risk of infection. Whereas the IPC, as you've heard earlier from my previous speakers, is made of silicone and is more robust. So this is a case vignette. So I had a 75-year-old gentleman a couple of years ago, severe COPD, bullous disease. He'd had COVID. He was in hospital a while. He wasn't stable for a bronchoscopy. He was in a wheelchair, could only manage a few steps. And you can see his lungs were like Swiss cheese, really severe emphysema. So we put an 18 French drain in him. We put an ambulatory bag on him as a Heimlich valve, sent him home for 4 weeks. It still wasn't resolving. And we were a bit twitchy about keeping this drain in because of the infection risk and the risk of it falling out. So we put an indwelling pleural catheter in, so an indwelling pleural catheter for a persistent air leak, took the 16 French drain out and allowed him to home with a bag. Because when you put an IPC in this patient, there's a one-way valve and they'll tension, so we put a bag on. You can see a month later, it took some time, the lung eventually re-expanded, and we then gave him talc via the IPC. And as you can see, we were able to remove the IPC, and actually reassuring his exercise tolerance improved, and he was no longer in a wheelchair and didn't need oxygen. Why? Because he's sort of done his auto lung volume reduction. You can see he's lost volume on the right hemithorax, which has sort of helped with his breathlessness and his emphysema as well. How about suction? I'm sure we all put patients on suction. Routine use, they say you should avoid because of the risk of reperfusion pulmonary edema, but where you do put patients on suction, you want to use low pressure, high volume. I often find that the suction you use on the wall, there's such a long distance to the chest drain that actually its efficacy is not great, hence why digital suction devices probably are more better. So digital suction devices such as these quantify the leak, you can be accurate about the pressure you set, the patient can be free from the wall, they're not confined to the bed, they can move around, and they can even actually go home with it if you dare. And this has been shown to be useful in a number of studies that's already been performed. And the RASPER trial in the UK is looking at the utility of suction versus no suction in primary pneumothorax, and this is ongoing in the UK currently. So how about localizing the air leak? So we've got this bubbling chest drain, and we want to know how can we find out where it is? Well, if the patient's fit for a bronchoscopy, you can perform a bronchoscopy and put a Fogarty catheter in, or a Chartis catheter, which is what we used prior to putting a valve in. And if the patient has got a drain in, when you inflate the balloon, if the bubbling stops, then you know that's where the culprit is and where you need to do some sort of intervention. The other alternative is to use, but actually that's quite tedious because you're putting this balloon in multiple segments and it's not always that satisfactory. The alternative is to use methylene blue. So you can put methylene blue through the chest drain and some of it might be absorbed into the lung and you'll be able to see which segment is the culprit, where you might be able to put a valve or a spigot. But ideally you probably want to use a combination of the two techniques. So put methylene blue in through the chest drain and do the Fogarty catheter so that you see where the methylene blue is endobronchially, and hopefully that'll direct you to the segment which needs some sort of intervention or which is the culprit. If the lung does come up, you've heard from my predecessors, Professor Mohan, who stated that from this Cochrane review, talc is the most efficacious pleurodesis agent. But at the bottom, you've also got this Viscum album. So this is European mistletoe. So European mistletoe exerts an immunomodulatory effect, and it's been used in oncological treatments in some parts of the world as well. And this Fraxine is the only available compound, and that can be used, has been used in persistent air leaks as well. So how about autologous blood patch? There's these two nice systematic reviews, okay? So the main findings from this is no one really knows what dose of blood to use, but it's cheap. It's the patient's own blood. They're not going to get any reaction to it. Ideally, you probably want to use 1 ml per kilogram, so somewhere around 70 to 75 or 80 mils of blood. Ideally, one of the concerns is when you put the blood in, it may block the chest tube and there's a risk of tension. So you might want to use a larger bore drain, 18, 20 French or larger. Often when you do a blood patch pleurodesis, you need to repeat it. Okay, so you might have done it once, you might repeat it a second time. And a success rate is variable. Again, it depends on the duration of the air leak. So how do I do a blood patch pleurodesis? So you've got a bubbling chest drain, you'll put the patient on suction, the lung is up. As soon as you take the suction off, the lung goes down. So you're playing this game, up and down, up and down. So what I do is, while the lung is up and the patient is on suction, you'll take 50 mils or 70 mils of their own blood, you'll inject it through the chest drain, and you put the patient back on suction immediately. Now the concern is when you put the patient back on suction, the blood's just going to come out. So we tend to hang the tube over a drip stand, as you can see in the bottom corner. Okay, so you put the blood patch in, you hang the chest drain over a drip stand, and put the patient back on suction to keep the lung up. So if you're putting the lung up, hopefully the blood will act as a glue. You can also do endobronchial blood patches as well. So blood patch is safe, it's inexpensive, and the theory is that the blood clot basically covers the breach in the visceral pleura and will lead to fibrin deposition, inflammation, and it'll seal the leak. The main concern, and you should consent the patient for this, is when you're using blood, there's a risk of infection because these chest drains have been in longer than usual. So endobronchial valves. So this is in press, and this was an expert statement or recommendations from a number of European leaders in sort of IP, which you'll be familiar with. And they stated that valves will lead to resolution in more than 2/3 of cases. So there are 2 endobronchial valves available on the market at the moment. There is the spiration valve by Olympus and the Zephyr valve. So again, it's the same principle. You put this catheter in, or a Fogarty or a Chartis catheter, you blow the balloon up, and you put a valve into the segment. You're not doing lung volume reduction here. You are just sealing the breach in the visceral pleura in the segment that is the cause. Okay, so you may only put 1 or 2 valves in. You're not you're not causing lobar collapse or lung volume reduction as such. If you have a digital device here, then you can put the patient, you can see that the airflow will go from like 50 mils, 100 mils down to 0, and you know that's the segment. Again, a good success rate. One of the risks of the valves is the patients may cough it out. It can lead to granulation tissue. This is a 31-year-old gentleman I had from Delhi here who has smear-positive TB with a complex bronchopleural fistula. The surgeons were reluctant to touch him. They said he needs a month's worth of sort of antituberculous treatment before we even touch him. The lung will be very friable. And I would like to ask our surgical colleague how they their concerns about TB patients with bronchopleural fistulas. So the surgeons were not keen. We put a drain in. I eventually put a couple of valves in and the lung came up. The lung actually then went down, and then by this time he'd been in hospital so long that my surgical colleagues decided to do a partial decortication. There are other bronchoscopic methods available, so these Amplatz devices, then there's glue and fistula plugs as well. The BTS says there's insufficient evidence to recommend for persistent air leaks, or what's the best treatment. So I'm just sort of going through the summary of the evidence out there. So key thing is treat the patient, not the X-ray. Lack of guidelines. You need to individualize the treatment of persistent air leaks. You need to have a toolbox of approaches. Consider ambulatory management. Consider blood patch. You may need to repeat it. And obviously there's a number of endobronchial approaches. And remember, just have close liaison with your thoracic surgical colleagues. And I think MDT working in these cases is absolutely key. Thank you very much.
Well, I must say that the lecture I'm hearing again, but each time when I hear a different lecture, same lecture, different point of time, I learned something new. It was very sharp and to the point, precise. And I think we couldn't get a lot of opportunity to discuss on the stage about what is his views and the elaboration of the points which he has discussed. So now I would request Dr. Richa ma'am to moderate this session and take us further through the discussions with the national panelist as well as the international expert. Richa ma'am, please.
So thank you so much, Kanishka, and thank you, sir, for providing the platform for discussing something very, very important, which in day-to-day life we are seeing. And of course, Rakesh, your comprehensive review was on spot. There have been, when we talk about the bronchopleural or alveolar pleural fistulas, I think there is a difference in the demographic of the patients, the disease of the patients, and the type of patients we see in India. So first, I would like to ask from Dr. Jairaj as well as Dr. Balaraju about how often do you see persistent air leak in your clinical practice, and do you agree on the cutoff of 7 days to say it is PAL in India, especially I'm talking about. So, Dr. Jairaj, you first, and then Bala can answer after that.
Thank you for giving me the opportunity, Dr. Richa. This is an excellent platform, and I think Dr. Rakesh Panchal has wonderfully, covered up quite some interventional procedures. But as rightly, madam, you have said that the profile of patients are different. If I have to see, yesterday I had a 450 patient OPD, and there were 3 air leaks, of which 2 were actually tuberculous. And the problem is, I have to give them time. That 7 days cutoff for a tuberculous patient is not going to be, valid. I need to initiate them on a rifampicin based, considering that they were drug sensitive. So a rifampicin based anti-TB treatment, you need to give a minimum of 2 weeks for the anti-TB drugs to work. And this can be extended up to 4 weeks if you see the expansion happening. So as you rightly said, alveolar pleural fistula, it's one of the cavities which has ruptured in tuberculosis we are talking. So a cavity has about 10 raised to 5 bacilli or more than that per ml of sputum. So, that's what we have learned traditionally. So to reduce the burden of mycobacteria, you really need to give that adequate time of anti-TB drugs. So I will put the group for 2 to 4 weeks for tuberculosis. Now, it's not just TB. This is a lung abscess. It has also concomitant bacteriological flora there. One of the patients of the 2 yesterday that I saw had a recurrent pseudomonas. Now, this patient has been in and out of the hospital. So there is often a secondary bacterial hospital-acquired infection. So we were trying to treat the pseudomonas while he was on anti-TB treatment, and the surgeons were like, they wanted the culture to be negative because they did not want to touch him without, getting these 2 parameters, negative. Then the third patient, which I would say is the COPD with multiple bullae. Now, the problem with this third patient was he had, 2 different, CT guided on the CT imaging, HRCT, we could see that there were 2 different bullae which was communicating to the pleura. So there were 2 different things. So interventional at that time, I could think was only VATS. where, two different things needed to be sealed at that time. And then we see ILD patients who have this shrunken fibrotic lung. I think one of the chat questions were that you have a fibrotic lung, and one of the, honeycomb or this has ruptured and an alveolar pleural fistula has developed, and that requires an entirely, different intervention. I think
Right.
this much I will stick to,
Sure,
madam.
sir. Thank you so much, Dr. Jairaj. Dr. Bala, quickly.
Jairaj sir has summoned everything because he's seeing so many cases because he has touched upon COPD, tuberculosis, lung abscess, and everything. This is what we see in India. Majority is tuberculosis burden, and most of the time this is what happens because they end up with a chest tube for some time. As rightly said, I don't think 7 days is a good number in India at all. So we need to give time for the drugs to act. But I only had one thing because. Uh, in the West, if you have an MDR tuberculosis, they usually keep the valve or the spigot to for the tuberculosis bacillus to heal faster, because that point can be tried in cases of like MDR treatment cases, but not for a routine drug sensitive tuberculosis, I feel.
But Bala, I would say here that, an open case of MDR, if at all it is, with a BPF, I think nobody will dare to do
Exactly,
any bronchoscopic intervention at
exactly.
that point of time also.
That's the main problem.
The main problem. Dr. Rakesh, you want to add on something? Because otherwise I'll move on to my other query, actually.
No, not at all. I was just going to say it's a pleasure to work with the PACS group again and to share this platform with distinguished colleagues, because you guys, are managing this day to day, and the volume of work you see in India and TB. I work in Leicester, which, as you'll know, has a lot. We are actually now the #1 hotspot for TB in the UK. We've surpassed London recently. And you're completely right. These definitions of persistent air leak are arbitrary and written in the West. And when you read any research, any guidelines, you've got to say, how applicable is this to my local population, my local demographic, and my local pathophysiology and disease process? You're right. In TB, my surgeons won't touch patients with TB with leaks. They say you need to give the drugs a go. It's got to settle. The tissue is very friable. It's necrotic. Will just cause more harm. So I completely agree with you. And I think it takes time, longer than we anticipate. And sometimes I think as clinicians, when we're dealing with any sort of leak, we are looking for radiological resolution. That's what we want, isn't it? Our mind, we physically feel better when there's radiological resolution. And in these patients, you're probably not going to even achieve that in the majority, are you? You're looking for some improvement. But yeah, that's all I've got to add. I completely agree with Dr. Jairaj and Dr. Bala.
And I also feel that the cutoff which has been given is probably by the surgeons and post-surgical fistulas, so they wanted to operate early. So we'll try to do it because I think we have to take the questions also, and we have left with only 30 minutes. We'll quickly do the discussion on something which is very close to me as well, the debate kind of a thing. We can put our for or against whatever. So I wanted to ask, do you routinely apply suction to the chest drain in the presence of air leak? One thing, because Rakesh has already told one study is going on. We are waiting for that RCT results to come, and that will give us an answer. If I'll talk about practice at my institute, we do not apply. So I just wanted to know quickly from our international as well as national experts.
So very quickly, Risha, so for primary spontaneous pneumothorax, I do not put them on suction routinely. I will probably wait at least 3 or 4, maybe 5 days. If it's persisting, then I will probably seek to use it. But as you know, the evidence base is limited. There's proponents of it and it's not in guidelines. We don't know whether it will exacerbate the visceral breach and impair healing. And if you do it too early, there's the chance of reperfusion. In secondary pneumothorax, so in primary, I won't reach for it straight away. In secondary, again, I will wait, but perhaps my threshold would be lower to put them onto suction in a secondary to some extent, but not immediately. Again, there's this sort of knee-jerk response. The X-ray is not improving. 48 hours, let's just put them straight on. In a secondary, the leak might be bigger, the visceral breach will be bigger, and you'll certainly exacerbate it, I think. So not immediately, definitely not.
Right. Dr. Bala?
Till now, I've never put suction for any secondary alveolar pleural fistulas. Till now, I've only used suction only once, that is -10 or -20, while trying to localize the bronchus. Because the problem, what happens is once the patient is in supine or in that deep sedation, so sometimes when you start the procedure, all of a sudden that the bubbling stops. So we really don't know whether the bubbling is stopped because something it's not communicating, or all of a sudden, see, only at that point in time I use the suction. Otherwise, and my localization with segmental with balloon is very poor. It's hardly 50% of the times I can find the segment. But only in that situation I've used a suction. Otherwise, to be very honest, never till now.
Yeah, so mine too, Dr. Bala, hardly ever able to, locate with balloon occlusion where is the leak. Dr. Jairaj, your quick view on
Yes,
suction with
madam. Thank you
suction.
for bringing up that topic. And I think I join your gang, of course. There's no doubt. And for as Dr. Rakesh Panchal has said, primary spontaneous pneumothorax, they really expand immediately after the intercostal or a small bowel drain that you put. The lung immediately expands. When we are talking about tuberculous, we already have seen a cavity probably underlying, and by applying a suction, you really are not allowing rest for that alveolar pleural, rent break that you have, breach that you have. You need to give it rest and antibiotics. I mean, chemotherapy. So I think even I have hardly used, I have advised a couple of CVTS surgeons when their lung is not expanding, but that is after I proved that there is no endobronchial obstruction. So
Post
it's not
surgery.
like we have missed a mucus plug or a post surgical clot in the airway that we have missed before you apply suction.
Right. So as opposed to the CTPS surgeons, actually they prefer to apply suction.
Yep.
Uh,
Immediately post surgery.
Immediately post surgery. So I'm not very sure still. So do we, can we say something like that? If it is a large fistula, probably do not apply. If it is a very small kind of a things taking time, apply and see and pleurodese. Will that make sense? I mean, if you have to give some message to the audience.
So I think you're right. The use of digital suction devices and suction generally is extrapolated from our surgical colleagues who have operated, they know there's a big leak, and we're sort of extrapolating that into our physicianly type patients, right? And I agree with all of you that we don't know about suction. We shouldn't be using it routinely, but we use it as a last resort. And if you do, it's got to be low pressure, the slowest pressure. Some people don't even tolerate it at all. But you're going to, and as Dr. Jairaj said, the lung needs rest to recover from the insult that's on it. And you're just exacerbating that if you go in too quickly. And I think the patient wants quick resolution. The doctor does as well sometimes. And that's what drives us to do this. But patience is really important. But I think a lot of us will resort to it as a last resort to perhaps try and get that lung up, but then you end up playing that cat and mouse game, don't you? Up, down, and then it's what do you do with that? When I'm using blood patch pleurodesis, the suction again, not always using suction, but if the lung is going, I don't know about you, do you routinely, before you're removing your drain, do any of you clamp drains to see if it's going to go down before it? Yeah, exactly. So when you clamp it, you're playing that cat and mouse game. So what I do is clamp it, lung goes down, unclamp it, lung comes back up. So you think, well, when am I going to be able to pleurodese this patient? So what I'll do is unclamp it, put blood in, hang it over a drip stand, and put them on suction just to keep it up, so that the glue works. So that's when I would suggest potential definite or use of suction if you're playing that cat and mouse game.
Yeah, probably that gives a probably a more objective indication to put it on. But just a word of caution to the audience, I would say, if you are applying suction, which has to be low, that is less than -20 or max -20, at that point of time, you have to be careful, and you have to keep. I mean, patient needs to be seen regularly, because there are chances that patient may end up having subcutaneous emphysema because of the increase in the leak. So that is one thing. Let me just go about what is the profile of patients. So this is to Dr. Jairaj and Dr. Bala. what are the patients, profile of patients you would directly refer to surgeons without waiting? Is there
Um,
like that or?
yes, ma'am. I would I have actually never referred anybody directly to the surgeon, because first thing, I think your 2 weeks time is spent in getting the diagnosis of your bronchopleural fistula, whether it's tuberculous or we are just handling a bacterial one, and then of course we do a CT to look for underlying COPD, cystic lung disease, ILD, any other reason why this patient is suffering from a bronchopleural fistula. But I really can't think why would I urgently refer this patient
No,
to a
no, no.
surgical.
I'm sorry, Dr. Jarai, sorry to
Yes,
intervene in between.
yes.
What I'm saying is, you have a patient with whatever etiology, various etiologies it would be, and the patient has bronchopleural or an APF. So, is there any profile of patients who you have put a chest drain or you have done medical thoracoscopy, whichever, but you feel that there is a air leak? So, is there any profile of patients whom you don't want to wait for more than 5 days, 7 days, and you would directly, without your intervention, would like to refer the patient to surgeon?
I would consider first two. One is demographically a younger population age group, where I do not want to, they are both surgically also much fitter than an elderly patient. Second would be a unilateral disease patient. Like, I'm not talking about tuberculosis where there's bilateral and their outcome is going to be poorer. So I think these are the two things which I could think of, Dr. Bala.
No, exactly. See, this is what preserved lung function, unilateral bullous lung disease, a COPD, immediately surgery. Because in these cases, because once you do a surgery and you finish off that bulla, you don't have to see them back again. Because by the time you finish off the bullectomy, they'll do a pleurodesis on table, pleural peel. They will finish it off. So at that time, most of the times the job is done. So we don't have to wait on them to say, okay, that's going to heal slowly. So these are the first set of group of patients which you can definitely say, okay, we don't have to wait, just go ahead straight away. And Dr. Nair sir has already said, and Madam has also pointed out, secondary pneumothorax is tuberculosis, lung abscess, ILDs. Yes, these are the cases you need to think twice to refer them, because most of the times they will not take these cases because chemotherapy has to go on for some time, then only we can think about. And I'm sorry to say, in my practice most of them will land up with an ICD waiting for them for that lung to re-expand.
Agree, I agree. And even surgeons wants to take the more fitter patients where the outcome is seemed to be good. And that is how the branch of interventional pulmonology has cropped up, because nobody is taking that poor physician. We have to take in. Okay. So other questions again, when would you intervene? So we discussed earlier that 5 to 7, probably in our Indian population, because for us, most of the time it is TB as the underlying etiology may not be a right time. So when would you like to intervene, and what is the mode of bronchoscopic interventions you would do? And do you have any, so these are two parts. Do you have any particular, this bronchoscopic intervention is better, your clinical experience, or it is just because we are more experienced in doing, say, glue, I would like to do glue? So it's a little big questions, but I want everyone, even Rakesh, to pitch in, and let's just find out an answer to it, when we should intervene and what is the most uh, preferred mode of bronchoscopic intervention. Again, it will depend on different people and their expertise as well, plus the availability. So the valves are not yet available in India, Rakesh, but Olympus is planning to get it soon. So I think in a quarter or so we might be getting it. But as for now, we don't have the these thing valves. Yeah. Bala, you want to start
Yeah.
first?
So in India, everything boils down to who's going to pay for it. So that's my problem. So
Mhm.
because you know your group of patients and you know what has to be done, you know your theory, and because most of the times we are dealing with tuberculosis, with bronchopleural, alveolar fistulas or a lung abscess. So, so treat the infection first, either the lung abscess or the tuberculosis first. Wait for some time. So I ideally wait 4 weeks minimum. So without even hesitant, I'll place them as a chest tube, seal it well, IPCs again, whether it is an IPC or a chest tube, it depends upon. Most of the times they'll go home with a chest tube, and they come back again to see what's happening, what's happened to their lung, whether it is healing, whether it is closing off. Because in my practice, most of the times, the moment you keep the ICD for more than 2 weeks, I have seen that spontaneous pleurodesis happening already. At least what will happen is that you will see a localized pneumothorax somewhere in the top or somewhere in the down, and the bottom of the lung has nicely expanded well, and there will be pleurodesis because the ICD is already there inside the chest cavity. And I didn't had to do any bronchoscopic procedure, to be very honest, in these cases uh, for tuberculosis. In lung abscess, yes, we had to do a lobectomy because the lung abscess was not healing. The pleural fistula, I mean, the fistula was not getting better. And we gave antibiotics for 2 weeks, and we posted them for surgery for lobectomy. And luckily, there was no stump leakage problems, and the patient went home well. So these are my very small experience with alveolar fistulas. This is what we see. And again, likewise, I said bullous lung disease, unilateral, preserve lung function, direct surgery. There is no need to wait for them to put an ICD and wait on them. So I don't do that. So regarding bronchoscopic, yes, I have not done, because probably I might try a spigot because valves are not available. Glue, I don't know how much to put in, because the moment you push the catheter inside the bronchus, you don't know where it's going, which subsegment it is going, and you need to fill the whole lung with glue. I'm not very confident in putting a glue. Probably I would try a spigot first if I could identify the segment well,
Right.
and that's another challenge.
That's true. Dr. Jayraj.
Uh, Thank you, ma'am. Once again, I think we'll keep the TB part aside. As in a COPD with bulla, I would try to do a bronchoscopy. So if the alveolar pleural fistula, I can do a simple check, as it's all mentioned in our literature, that we use our bronchoscope as a wedge against what our suspected opening is. Once you've done the HRCT, you know you're talking about upper lobe or lower lobe. And once you enter into that, you can go to the segmental bronchus and apply your bronchus as a wedge. And this is a simple test by which you can just check if the ICD is bubbling and it has stopped bubbling after you've wedged that bronchoscope. The same thing, we have an ultra thin bronchoscope also, which you can use it to go deeper down into, and you can check which subsegment is getting affected. So these are the two simple tests while you're doing bronchoscopy you can check in, so that you can delineate which is the intervention you will look for. A couple of times in tuberculosis patient, I have actually gone to the left lower lobe and found that my segment 8 and segment 10 both are showing bubbling. And I think this is patient is not to be considered for intervention, because you have two big bronchopulmonary segments which are leaking. So I think we just have to give them longer time. And probably this patient may be benefited by a VATS when there are two different openings in the lung and they need to be sealed off separately. And probably our medical pleuroscopy is not the mode of intervention. Then you can use it to just find out the site of fistula. Man.
Sure. Dr. Rakesh?
Yeah, no, thank you. Your CT is really important because it will try and tell you where, systematically looking at with your thoracic radiologist, of where the breach in the visceral pleura is, but also to make sure that there is fissural integrity. So if your fissure is incomplete, then you're going to have collateral ventilation. So we often think of the lobes of the lungs, so right, 3 on the right, 2 on the left, and they are distinct entities, but there is communication between lobes. And the CT can sometimes tell you, looking at in the sagittal, in the coronal planes, where is the fissure, and is it the integrity of it maintained? If there is a breach, then you're going to get collateral ventilation, and then whatever you do bronchoscopically is not going to work, because you could make things worse. Actually, you're going in and putting things in glue, you're putting in spigots, valves, and then actually what happens is they get compensatory hyperinflation of another bully, which bursts, and then you get another pneumothorax. So actually, in some of these COPD patients with bullous disease, it is difficult. So use your CT. Is the fissure intact or not? where is the breach in the visceral pleura? As Dr. Jayraj said, maybe one or two or three areas. Then, bronchoscopically, obviously, we've got the option of valves, but you say you've got spigots. I'd like to ask colleagues whether they go back in and take the spigots out of this. I think there's 3 different silicon spigot sizes, whether you leave them in or whether you go back and remove them. Some of the literature says you should remove them. I've not used glue or anything like that. I know my surgical colleagues have, but as Dr. Bala said, it can be very messy. How much do you inject? Where do you put it? And you start putting in multiple segments, and it gets very messy. The other option is endobronchial blood. So, like you've done blood patch pleurodesis through the chest drain, you could also try endobronchial blood, which is probably less messy than glue and probably less risky. Again, you're using the patient's own blood, but the risk of infection. And going back to the TB, you probably remember in the presentation that I discussed that TB patient we had from Delhi, and it was very complex. And I'm sure you guys see this all the time. And our surgeon operated, so, we put a drain in, we put an IPC in, we tried valves, and then the surgeons tried to operate after, I think, over 4 weeks. Some help, but then it reoccurred. And this is for the really complex patients, and I think it came up in the discussion at PACS. Has anybody, and I'd like to ask you guys, how about the use of pleurocutaneous windows in some of these patients? How about that? Because you got that negative pressure there, and sometimes by creating that window, you're going to equalize the pressure, aren't you? And that might help over time for the lung to re-expand. So that's my sort of apologies. I'm not answering. I'm posing a question, but it's something that came up in the PACS meeting.
Yeah, I think this pleurocutaneous window is something which probably our surgeons would have preferred to do on a patient like that who has bilateral disease and the leak is not improving. They would have done it. And over time, it does heal. So that is one thing. So again, the bronchoscopic intervention, I mean, what we have experienced at our center is with the glue and the spigots. The idea is, but again, and blood patch, of course, but somehow, I don't know, we did some 5 patients with blood autologous blood pleurodesis, and out of that 3 patients got the infection. So since then we got a bit scared, and we have not been using it for long. I would say maybe years now. We haven't, for maybe 5-6 years back is what we stopped doing it. So that is our experience. And as you say about the spigot, yes, so the idea is once the healing happens and the seal is closed, you pleurodese the patient and you remove the spigot. So that's it. So would also like to ask about the role of pleurodescence in sealing because you have mentioned in your talk as well, Rakesh, about how does it help? When should we act? When should we do pleurodesis? One thing is for me, like if once the lung is expanding on a chest X-ray, the leak is small, you do it. Or how does it help? All expert opinion from all 3 panelists. And if Kanishka wants to add at their center how they are practicing would be and bonus for us. Yeah, you start, Rakesh. Yeah.
Yeah, so in the patients you've just alluded to, where the lung is up, it's a secondary pneumothorax in an emphysematous type patient. Our surgeons, as Dr. Bala said, will choose to operate, if the lung function, the performance status is good, minimal comorbidities, lung function, unilateral disease, etc. But they will tell us more often than not pleurodese. And sort of for these secondary pneumothorax, I have used talc. We know from previous talks that talc is the best pleurodesis agent. And sometimes in these patients, I've used sort of talc blood or blood talc blood. So my experience is you're very lucky if if you just do it once, it works. That's great. But often you're doing it 2 or 3 times. For the blood, it's cheap, it's easy. No one knows how much to really use, but I normally use 50, 60 mils, a mil per kilogram. Not only does it cause adhesion formation and inflammatory response, it's thought that it sort of coats the visceral breach, and I think it works. I think it and ERS and BTS guidelines would suggest that that is probably one of the things we should reach out to. But have I used talc as well? Yes, I have. I think colleagues earlier also said that in some of these complex patients, the lung will re-expand at the base and you're left with an apical rim. As I said earlier, don't always aim for radiological resolution. In these complex patients, you have to be satisfied with what you can get at what you achieve. And we all aren't we? We're doing that daily X-rays and saying, "Oh, the lung's not up. I want it to be perfect." And don't aim for that. You know, if the patient's hemodynamically stable, getting better and clinically well, and you're left with a small leak, or it's probably the best outcome they're going to have.
Dr. Jayraj, you want to add on?
Yes, I wanted to add. So while we are discussing here the ILD and COPDs who have, come with a pneumothorax, you put in a drain and the lung is, immediately expanded, or maybe a couple of days, and the lungs have expanded. While we are talking about having an opportunity for a pleural access to do the pleurodesis, now we have shifted from povidone iodine and tetracyclines to talc. Talc has been really good, with almost no recurrence practically. While I was doing this since the last few years, I have some of my students who have gone into the transplant program, and they are the ones who have been telling, don't pleurodes because we need to remove that lung, if this patient is a future transplant, recipient. So that was one thing, we have to always keep in mind, maybe not a COPD, but ILDs, IPF especially, we should keep that thing in mind that if you're going to pleurodest them to prevent pneumothorax, are they a future, are we stopping them from, a future transplant option for them, so now they are putting DLT, like, double lung transplant everywhere. So just a point that I wanted to bring about in those with pleurodes that we are planning.
Dr. Bala, your views on that?
Yeah, I'm never comfortable using a blood patch. I've never tried. I've tried only once talc, miserably failed. So after that, I made it a point. Again, I said, at least a bullous lung disease, surgically intervenable case, don't even touch anything, just straight away refer them. Because putting a talc, messing the whole pleural cavity is a nightmare for the surgeon. Because once you put a talc, it messed up and you call the surgeon and said, why did you put the talc? Now it's my job to clear all those things. It's a difficult scenario because I usually discuss with my surgeon first, like, what do you want me to do? Like, should you try this or not? So that is what I feel. And blood patch, absolutely, ma'am. I think you echoed my thoughts because I was very, very worried about the infections. Because that's the reason I have never tried blood patch at all. Because even though I had cases, but I never tried blood patch. I was very, very skeptical of blood patch. Because yes, the infection rates in India compared to West are very, very different. Probably that's the reason, because most of the ICDs what we have, it will be more than 1-2 weeks. The moment you inject anything, not blood, just saline also, if you inject something inside it, I am very skeptical that this infection will go inside the pleural cavity and it disturbs that cavity. That's the main reason I don't inject anything inside the pleural ICD tube. That's my fear.
So Bala, can I play devil's advocate? So your person, I suppose what people want to hear and what we all dread is that patient who's not for surgery, who has got that disease that needs intervention,
Yes.
Who has had a prolonged chest strain. What do you do? Because there are risks and benefits of everything, and you have to make a judgment call at the end of the day. It's a risk-benefit ratio at different points of their disease trajectory or their timeline. That risk-benefit ratio is going to change. Like we were saying, no suction to start with because it does harm. Then that risk-benefit changes at 3 weeks, 4 weeks.
100%.
The surgeon says no, so we're doing this, and at some point. So I suppose my question back is, totally hear you about blood patch. I have used it quite a bit, and I'm not saying it's the panacea, but it's an option, and we know that is in the literature. And in terms of the pleurodesis agents for persistent air leak, it's one of the ones that is a recommendation. What do you do?
That's what I've never tried blood patch, only tried talc. But that too, when the fistula is very, very small and the lung is expanded, just tried talc in only one case, and I failed. That's the problem.
Okay, so I will use talc in the first instance in, let's say, a small leak that's come up. The surgeons have said no. Okay, if it's a much larger leak, I'll probably use talc, and then if it fails, I'll do blood patch. I might use blood patch twice. As I said, I will have to use some modality or a combination of those 2 or 3 times. And even then, I'm not saying it's great, but you may get some apposition.
Yeah,
And
sure.
as Dr. Jairaj said, I think the hardest ones are the ILD ones, because there the lung is never going to come up. You're going to have to make some compromise of that it's come up so far and that's as good as you're going to get. And with the transplant issue, yeah, that's really true. And I think sometimes maybe blood, I don't know, maybe better than the talc, because it's the patient's own stuff, and sometimes the surgeon can find a dissection plane. But what do? They're on the transplant list and it keeps happening.
Yeah,
The surgeon might say, try blood.
sure.
I have an option for this, Dr. Rakesh Panchal. I think a Heimlich valve, it really serves a purpose. When you don't have a drain, it's only air leak that you're worried about. And all you need to is just, bandage that Heimlich against the chest wall. And that's it. It's a one-way valve, allow the air to move and let them wait for, on the transplant list. But that I don't do it for my COPD patients. My COPD patients are not going to undergo lung transplant as of today. It may be different 10 years down the lane, but all my COPD patients undergo talc fluoridesis, because this is my opportunity to, I know there's so much of emphysema, all 3 types of emphysema, centrilobular, panacenar, paraseptal. I do not want to lose that opportunity of giving them that fluoridesis option. So definitely yes for COPD pneumothorax, ILD whose lung is just not expanding. I would give them a Heimlich one-way valve option so they can go home. They can be mobile. They can wear a shirt upon it, and it's not seen outside. And just somebody got out that plurocutaneous thing. I have 2, 3 patients who my CVTS department has provided a thoracostoma. What is the term that they use? That's a window. And I can actually, this was more used for somebody who has undergone a pneumonectomy and there's a stump blowout. And you have the other lung disease, you cannot operate this patient again to close that stump blowout. So these are the patients where my CVTS people has decided to give a rib resection of maybe 1 or 2 and provide and gradually over the period of time that muscle myopedicle takes up and epithelializes, and then you have a nice skin kind of going into that window, and you can see the air leak always present, so they are free of the ICD. So these are my views on it.
Thank you so
Now,
much, everyone, for your inputs. I think we are running short of time now, so I'll hand over to Kanishka to take up the questions from the audience. Quickly, Kanishka.
Yeah. Thank you so much, ma'am. Regarding the last question, it was a wonderful discussion, and I couldn't agree more with whatever we have discussed. We just wait for the lungs to expand at our center, do the talc fluoridesis, take care of the lung transplant thing, as well as talk to the surgeon and the patient and their relatives for the surgical fluoridesis as well. So this was my gist of what we do for the last question. Now we move on to the questions from the audience, which is the most important thing. And I have few questions. So I'll be asking one of the panelists, and then I'll be asking Dr. Rakesh Panchal sir for his final opinion. So it's a big message. I will just convey it to you. It's from Dr. Sujit from Maharashtra, Mumbai. A patient with a bad fibrotic lung disease, 38 years old with bilateral pneumothorax. The patient has a bilateral pneumothorax. Now, lung tends to collapse with the reduction of negative suction. So when he reduces the negative suction, it tends to collapse. The patient is hard to mobilize because of that. Failed bleo, he has written, I think it's a bleomycin, pleurodesis, because of the transplant concerns. Maybe he has used the bleomycin. Failed talc pleurodesis on the same side now. Now it has become very challenging. So what do you suggest? Either the insertion of spigot or send for surgery, high risk surgery, or put the patient on the wait list for the transplant. I request Dr. Jairaj Nair sir to please put this
yeah,
up.
a wonderful question and a rare patient, both together. It's a 38-year-old end stage ILD and waiting on a transplant list. I would think of conservatively without doing much, assuming that his lung functions are really poor, considering the lung is not expanding. As I previously mentioned, a Heimlich to allow one way and put him on the wait list. That's one option. Second option, if the patient is like not wanting a transplant either because of financial reasons or a long wait list, I would think of maybe referring to a surgeon for a VATS, where if it is 1 or 2, alveolo-pleural fistula, they can think of thoracoscopically guided closure of that. So these are the two things I can think for this patient.
Dr. Panchal sir, your opinion?
Thank you, Dr. Suji. That is a really challenging patient there, isn't it? A bilateral disease. I doubt any surgeon will want to touch them because to try and ventilate them is going to be nigh on impossible. You're going to exacerbate matter. So as Dr. Jayraj said, Heimlich valve in the first instance, but it's probably not going to work. The breach of the air is probably much bigger than the valve might tolerate potentially. If you can, putting a large drain in and trying with the Heimlich valve. You said about spigot. If the patient is fit enough for a bronchoscopy, you could try some endobronchial treatment while a valve is in. While the drain is in, you try some sort of endobronchial treatment, but it's very difficult. You failed talc, you've tried bleo. I mean, have you tried blood patch pleurodesis in this case? And my question would be, will this patient, is 38, ever be fit enough to get into transplant? But yeah, I don't have a great answer. Drain with Heimlich, try some endobronchial treatment, or try a blood patch pleurodesis on one side as well. Because even if they get a unilateral lung transplant, that's going to be better than nothing for him. It's a toolbox of approaches. This chap is running out of time.
Yeah. Yeah, there cannot be any single answer or what is right or what is wrong for this patient who is really difficult to manage. He's a young patient with fibrotic lung disease, so probably sequentially we can try one or the other technique, uh, uh, while we are waiting for him to go for transplant if he is fit to go that.
But at least all of us got some insight that these kind of situation might come, and what we have to do, we know that now. And moving on to the next question from Dr. Aparna Chatterjee from West Bengal, Kolkata. She asks to Dr. Rakesh Panchal sir, but I would ask Dr. Balaraju before that. On the utility of negative suction in a patient with persistent air leak, I think he has given his views. If any, it's really a nightmare to resolve the patient with PAL with big leak. So she is asking about the big leak and the role of negative suction. I think you have already shared your views on that. So yes, we move on to Dr. Rakesh Panchal sir. What's your view on this nightmare of non-resolving leak?
So I think in a patient with a big air leak, it's going to be bubbling away. If you put it on suction, you may probably just exacerbate it and make it even worse. It's probably not going to work in that instance. Because you probably really are dealing with an airway, like a bronchopleural fissure rather than an alveolar. So it's probably from the airway here. I suspect, Aparna, lovely to hear from you again. It's probably not a surgical candidate. Time, I can't think of anything here. Suction is not going to work here. If you can get the lung, you can try a large bore drain with some sort of ambulatory bag and Heimlich bag if the patient's hemodynamically stable to get them ambulatory and out of hospital. But you're just going to have to wait. But I would avoid suction if it's a very big air leak. You're just going to exacerbate the issue. I'm sorry. I don't know what other colleagues would say.
I would like to add that there's one case report of a bronchoscopic intervention along with a thoracoscopic for this big. And I would definitely not put talc because the last thing you want is talc going into the lungs. And theoretically it can cause ARDS. So I do not want that talc to enter into the alveoli. So bronchoscopic intervention simultaneously in the same setting, a thoracoscopic, either a blood patch or a repair that could be done surgically is the option for this large air leak. That's my input.
Okay, now we move on to the next question from Dr. Sonu from Tamil Nadu. What is the role of blood patch in persistent air leak? So I would request Dr. Panchal sir to tell us about the role of blood patch and where do you put that in your priority list in doing the pleurodesis?
So I think we've sort of covered this a little bit, but in response to Dr. Sonu, you'll try talc first. If it's a large leak, and as Dr. Jayraj said, you're concerned about talc going in and what that might cause. If provided the lung, you'll probably try talc first if it's a small leak and the lung is up. Let's say, be honest. If that fails and it's persisting, then I will take probably 50 to 70 mils of the patient's own blood, inject it by the drain, flush it with 20 mils of normal saline, hang the drain over a drip stand because you want to avoid what you put in coming straight back out. You want to flush it to avoid a clot developing and the patient tensioning. And then you might try and put them on gentle suction to keep the lung up in anticipation that as the blood clots, it will cause some sort of clot or fibrin deposition over the visceral breach, hopefully. And it'll probably work. If it's going to work, it'll work fairly quickly, hopefully. But that's my take on it.
So now the next question is from Dr. Deepak from Patna. I will request Dr. Balaraju to take this. Does pleurodesis directly help in sealing alveolar pleural fistula?
This we have discussed in this talk and in the discussions, because Dr. Rakesh sir has already said for large leaks, absolutely no, there is no chance at all. For small leaks, yes, you can try. You can give it a try and see. We are talking about non-operable cases. So you can give it a try and see whether it's sealing or not. If it is not sealing in one method, you can always try a second method. But again, your options are again bleomycin, talc, powder iodine, blood patch and all. So we usually use the talc first and see what's happening. Most of the times, the maximum times talc, that's what we use, and it has shown to cause the maximum pleurodesis. That's the reason that the first choice is always a talc. If you fail talc, and that's the challenging part. So what do you do next? Whether you want to reuse the same thing again or you wait on that case. So most of the times we tend to wait with a chest tube, and this is what happens most of the times.
Agree, sir? Dr. Rakesh?
Yeah, absolutely. I think I agree with what Bala says there completely.
So now we move on to the very rare situation, I must say. It's from Dr. Vimesh Rajput from Maharashtra, Mumbai. How do you treat tracheopleural fistula? Richa ma'am, your views on the tracheopleural fistula?
Thanks, Kanishka. So, valid question, but yes, rare occurrence. So, my first concern with this patient who is having tracheopleural fistula would be, the risk of infection, because you are opening your airways into something which is a sterile cavity. So, first thing would be to take care of that. If patient is fit for surgery, that would be the best. If not, then probably I would like to put a stent to seal off the fistula. The communication between the trachea and the pleura. That would be how I would do it in this patient. And that will stop the spread of the infection, from airway to the pleura.
What's your view, sir, Dr. Rakesh?
Yeah, I suspect, to be honest, these patients are largely managed by my surgical colleagues. I think it's important to speak to your surgeon in the first instance. And they, may choose to do the same as what Dr. Risha said. If not, then, in interventional pulmonologists who've got the experience of doing so, then I suspect the case that Dr. Vimesh is alluding to is probably not a surgical candidate, I suspect, in which case, yes, stenting is probably the option, as Dr. Risha said.
Now we move on to the last question of this session, which is from Dr. K. Anif, Andhra Pradesh. What's your take on customized endo blockers in persistent air leak? And he's telling that he had one patient which was unfit for surgery and under endo blocker placement, followed by the recurrence of pneumothorax. Now, what are the options left? The patient unfit for surgery, and what are your views on the customized endo blockers in persistent air leak? Dr. Rakesh, directly to you.
So we're looking to the future now, aren't we? So I think, 3D printing and people trying to design their own bespoke blockers. I suspect it's on. I don't know anything about experience of it, but I suspect it's on the cards. The other thing I should mention, and I forgot to say this, and this question has reminded me, is I'd seen this paper or something. There's lots of things on AI in radiology right now, right? So AI is also trying to help people identify where the leak is, what the segment is, and tailor where the approach might be on radiology to guide you to where the problem is. I suppose you could. I know people customize stents all the time, right? There's 3D printing of stents to match your anatomy and make sure it's a fit rather than choosing one of 3 or 4 options. One size doesn't fit all. So, yeah, I suppose if it works, it works. But we've said, as Dr. Bala and the team have all said, doing endobronchial stuff is tricky. Putting valves in for these endobronchial leaks, you might need to put 2 or 3 in, and then you put those 2 or 3 in, and then another one bursts somewhere else. Putting the gluing has challenges, the blood has challenges. So you may have to have 2 or 3 customized endobronchial blockers ready to put in. And but yeah, I think it's the future, I suppose, to some extent. But like people are doing 3D stent printing. I don't know what my colleagues think.
Do anybody wants to add something in?
I think I just want to add to Anif, this endoblockers, what probably he's talking about, is he talking about the customized stent where you close one limb and kind of a thing like that, probably. So I don't know, we are not, directly going, but I know him, so I will speak to him directly as well. So the thing is, whenever we put up those endobronchial things or that, if you feel that the leak is gone and the lung is expanded, pleurodesis should have been done at that point of time. I believe he's saying recurrence of the pneumo, so I really don't have an answer at the moment.
So
for
it was a tremendous discussion, I must say, and amazing response from the audience. It's always a great feeling to have such kind of response from the audience. But before we end this session, I request all the panelists and the moderator and the international expert to give one line what they want to convey in one line, the message that everybody has to take home from your side. I'll start with Dr. Jairaj Nayak.
Thank you, Dr. Kanishk. And my message would be uh, each case needs to be individualized, and you need to take case by case as to what are you going to do for that particular patient. There's no blanket rule that COPD you're going to do this, TB you're going to do this, and an ILD with a persistent air leak you're going to do this. So you have to take case by case and find out what is the best alternative. I think we have discussed all the options here. It's like a platter of buffet in front of you. You need to select one per patient and choose the right option for them. That's it.
Dr. Balaraju.
Yeah, I would say that as Dr. Rakesh sir already mentioned in his lecture, it is an MDT, right? Because you need to involve your thoracic radiologists, your thoracic surgeons before dealing with anything. What we can give a best solution to the patients, because it should be a tailor-made than individualized. Like, okay, you do for COPD, you do this, for this you do this. So that's not going to work in most of our cases. That's what I feel. Because to identify the segment, please speak to your thoracic radiologist. Like, where do you think the rent is there? So then, if you still have that bubbling tube in there and you want to plug it with a spigot, go back there, try to put the patient on supine, see whether it is still bubbling or not. Yes, if it is still bubbling, because I had patients, once I gave sedation, it stopped. So that's not going to work. So I feel that you should speak to the thoracic radiologist and the surgeons to tailor-made the treatment for each individualized patient. That's what I feel.
Dr. Richa, ma'am.
Yes, so I would say for our patients, you can wait and watch for some time. But of course, careful observation and careful follow-up is really, really needed. And when you send the patient on chest drain, please tell them how to take care of the drain. Otherwise, they will end up coming up with, really bad infections, one thing. And the second thing would be, do not try to do something which is not required just because you know that you can do it or you want to experiment on it. Please timely refer to your colleagues, your CTVS surgeons would be something I would suggest.
Dr. Rakesh Panchal, sir, your final verdict on today's discussion and the endpoints of this discussion.
I echo all my colleagues, and I would say have a toolbox of approaches, ask a friend, review the literature. There's always somebody who might have done something that you haven't and you can learn from, and treat the patient, not the x-ray.
So this was it. Today's discussion on PAL, persistent air leak. We got a lot of insights, lot of discussion, lot of questions, lot of answers, lot of options. So now we end this session, but we'll be seeing you next month on the last Saturday of the February, which is 22nd. And on that, we'll be discussing on, we'll have a discussion on biologicals in COPD. So I'll be seeing you next month also. And thank you all. Thank you, everybody. It's a wonderful and overwhelming response from all of you, all of the audience. Thank you.
Thank you. Thank you so much, everyone. Good
Thank
night.
you.
Thank you,
Thank you.
PACS, and all my co-panelists. Thank you.
Thank you. Thank you.